And yes, I was given the topic of preventive oncology in endometrial cancer, which has come in. Yeah. So this recent FIGO staging had come in 2023, and there were a lot of changes from the earlier, and the molecular classification that has come into it, and how we are using this for our treatment, and a little about robotic surgery. And I haven't included this in the slide, but I'll definitely touch on the, these pembrolizumab and all that we have treatment point of view. So basically, I think we already know, yes, endometrial cancer is on the rise. So we already know cervical cancer is decreasing, but endometrial cancer is on the rise. And this is the recent Globocan 2022 figures that we follow in endometrial cancer. Worldwide in India, we see 17,420 new cases every year. Deaths amount to almost 6,000, which is a very high number. And at any point, you have almost around more than 50,000 cases of C. endometrium. Now, we know the risk factors. Because I have to touch on the preventive, so I've covered these points. We have basically two types. We are aware of this, the non-aggressive histologies and the aggressive histologies. Non-aggressive, where it is estrogen sensitive, and the aggressive histologies, we are using these terms because the recent FIGO guidelines now use these terms. So these are some of the risk factors. We know tamoxifen. This is very commonly used after breast cancer. It is given when you are ER, PR positive, basically estrogen receptor positive breast cancers use a lot of tamoxifen. So when a patient is on tamoxifen, we will have in our clinics, breast cancer. We should also take care because we know tamoxifen has an agonistic action on the endometrium and can cause hyperplasia. Now, we know postmenopausal bleeding, the cutoff is, radiologists take it as 4. As gynae and gynae oncologists, we take it as 5 mm, postmenopausal hyperplasia, more than 5 mm. But when a lady is taking tamoxifen, we give it up to 8 mm because we know it causes endometrial hyperplasia, but we say more than 8 mm or any abnormal bleeding, yes, you have to take care. Chronic anovulation, we are aware when there is chronic anovulation, the estrogen increases, and estrogen again is a very high risk. Obesity, there are trials now that have come, I'll come later into these. I'll just quickly summarize them. Estrogen secreting tumors, we know granulosa cell tumors. Whenever we have a patient who comes to our clinic and say, we detect an ovarian mass, and she also complains that I have excessive bleeding and irregular bleeding, we should keep in mind endometrial cancer also, because granulosa cell tumors may be associated with endometrial cancers. So it is very, very important if a lady walks in and our inhibin are very high, we also get an endometrial biopsy done to prove it. So early menarche, late menopause, we don't have much to do about it, but definitely it's a risk factor. And heredity factors, Lynch syndrome, Cowden, and first-degree relatives is where preventive oncology actually comes into play. So basically, patients at high risk is where endometrial cancer, we have a preventive portion to play. Because in low risk, as we know, we do not have any screening for C. endometrium. So low risk patients, we can't keep screening them. We can't keep doing ultrasounds unless they have a problem or they are symptomatic. So it is not, it's not like cervical cancer where you do a pap test every 3 years if it's normal, or a co-testing every 5 years. So we don't have for low risk. But yes, for the high risk, definitely we have. And who are the patients with high risk? Patient with Lynch syndrome, patients taking tamoxifen, patients with PCOS also, and patients with obesity. And we'll discuss it in patients with average risk. What do we do from the preventive point of view? Now, these are some of the strategies for prevention that we have. Now, Lynch syndrome, as we were just talking, and somebody just asked, what is this MMR? Basically, we have some genes in our body, that is the MLH1, MLH2, PMS2, these MLH6. These are the genes that are mutated. When they are mutated, we tell them they are deficient. If they are proficient, they are normal. And when they are deficient, how do we detect them? Most of the times we are doing IHC in our regular practice. For every endometrial cancer these days, when we get a histopathology done, other than the estrogen receptor positivity, progesterone receptor positivity, we also do MMR, P53, and pole, which has come into this now. Now, when a lady, that is done on the specimen. We take out the uterus and the specimen. If it is positive, we get these tests done. If she's positive for this, we do a germline testing. Germline is a blood test. We do a blood test for Lynch syndrome to see if she is deficient for any other. Because sometimes what happens is she may not be a germline positive, just that tumor. That is a somatic change, that mutation that has occurred. So we do a germline. And yes, if she's positive for germline, then you have to also look out for colon cancer. We have to tell her, actually, basically, having said that, I'm not saying, genetic test is also can have its, negative effects. So we should have genetic counselors who are going to counsel them, because sometimes, patient may come, she may have a MMR deficient report with her. And we tell them, okay, you are at risk of colon cancer. It may play on her psyche. So, you have to have psychological counselors. You have to have genetic counselors who are going to counsel, who are going to tell them what percentage you're going to have. It is not that everybody who's a MMR deficient will eventually end up with a colon cancer. So, yes, the lifetime risk, this is what Lynch is, in the general, basically for the other cancers, it is higher. If you have Lynch syndrome, risk of colon cancer, and sometimes, the mutations in the DNA, risk surgery is what you have to offer to these patients. In fact, even for breast, something I just want to make it aware, and I'll just give you examples which I have seen in my clinic. Just in the past 2 months, I have operated on 2 patients. They were they had breast cancer. They were BRCA positive, young females. After 10 years, now they come to me with ovarian cancer. So in these patients, if they are BRCA positive, BRCA BRCA1 and BRCA2, if they are positive, they can be offered risk reduction surgery. Very, very important. Because if they are BRCA1, they are up to the tune of 45% risk of ovarian cancer, and BRCA2 are at almost 30% risk of ovarian cancer. And in the past, just 1 to 2 months, I have seen 2 such cases. One who came, she was complaining she was having irregular bleeding, and she must have gone to some doctor who gave her Trenexa for quite some time. She got an ultrasound down from outside, which showed a very small, simple cyst. But, when such a patient, and then her BRCA was positive, the first thing is I got her tumor markers done. And she already had an ultrasound. So for us, TVS is good enough. If TVS is not showing anything much, we don't ask for an MRI, PET CT, no matter, even if it's a breast CA. So she came to me with a so-called TVS, which did not show, just a simple cyst. Irrespective of that, I got her tumor markers done. Her CO125 was up to the tune of something 1099. Then I got a PET CT done. Of course, I got an MRI first. MRI showed her abdomen was full of disease. It was missed on. Yes, it was missed on that ultrasound. I cannot share details. Perhaps I could have put this. She was full of disease to the tune of that I could not go ahead with the primary surgery. I had to actually give her neoadjuvant chemotherapy first. The liver was there was disease in the liver. There was paracolic gutter. There was cirrhosal involvement. Because these days it's a very yes, we definitely have some criteria of when to give a neoadjuvant and when to do a surgery, but they can be surgeon to surgeon based, because nowadays it is not so fixed. If we have portocaval nodes, we also excise portocaval nodes, provided we can achieve a R0 resection. So, but her disease was so much, she had to go for NECT. And then there was another lady, but she was relatively around maybe in her 50s, but she was BRCA positive. She now came back to me with a full-fledged CA ovary. So sometimes, specifically in Lynch syndrome, it is advised that yes, when you are if you have completed your family, you're above 35 years, you have a Lynch syndrome, test positive, please go ahead, remove the uterus if you're done with your family. So this is something. Tamoxifen, as I already told, yes. PCOS also has a lifetime risk of 9% of endometrial cancer. Obesity, I'll show a few papers. There are papers which have proven that, your obesity has a direct link with endometrial cancer. And after bariatric surgery, yes, after bariatric surgery, the incidence has decreased, because we all know obesity, fat also causes estrogen. There is a lot of estrogen in the body when we have a lot of peripheral fat. So diabetes, these are some of the risk factors, we are aware. So this I am touching upon because this is something preventive oncology. You have a Lynch syndrome, go ahead with a risk reduction surgery. Tamoxifen, yes, you have to see them, you have to follow them in your OPDs. PCOS, a lot of these days, young girls, I'm mostly dealing into oncology, but I have a lot of young girls. I'm sure that must be in your practice these days. We would not see this maybe a decade ago, but now every young girl who walks in has PCOS. Very strange. They're coming with, and thin girls also are coming, irrespective of the fact, thin girls also are coming. So this is something. And with Lynch syndrome, yes, in case she cannot, she's somebody who has not completed her family, cannot undergo a hysterectomy, we give OCPs. If she wants to, take some time, decide to have a family, because after she's had a family, definitely. Endometrial biopsy is something that we have to do. If you have a Lynch syndrome, please get it done once at least and prove it that there's nothing there. And then when childbearing is complete, risk reduction, total hysterectomy is definitely recommended in such patients. Basically screen. Yes, ET. Basically, you have a Lynch syndrome, please make her aware that once her family is completed, because Lynch, how will you actually come to know? First thing, very important. Normally what happens is, all these molecular markers, all these IHCs don't have to wait for a hysterectomy specimen. They can be also done on a small endometrial biopsy if you have good tissue, because basically you just require IHC on that. These days we have next generation sequencing also. That is something a little more expensive. It is so you can just do with your immunohistochemistry. So in case you're suspicious, a young girl coming with, in case you are suspicious, or she has a family history, she'll be like, mere bua ko bhi endometrium tha, mere inko endometrium tha, and you're suspicious. Then colon cancer. So you're suspicious, then you can even send it on the biopsy. You don't actually have to have that hysterectomy specimen to get the IHCs done. Yeah. Yes. Yes. In the biopsy specimen, you have to specify that you want immunohistochemistry for MMR. No, they'll not do otherwise. They will just give. In fact, a lot of places, sometimes it really pains me also to see, they will just give, aajkal to anyways, a lot of pathologists don't even rely on the morphology any longer. There were times when, I come from a decade where I've seen so much of changes, when there was a time when our pathologist was just gave on morphology. A lot of things, whether it was clear cell, whether it was, adenocarcinoma, clear cell. And now they're like, we need IHC. Bina IHC, they will not give us. Okay, maybe they're also being safe on their side, because so much of, these days you have legal issues. So, but yeah, on the specimen, biopsy specimen, you have to specify, I require these, and then they do it. IHC is relatively cheaper as compared to next generation sequencing, which can also be done. A lot of genetic labs, MedGenome is one of the good labs. IHC is relatively cheaper because we get it done not more than maybe 10,000 or something. Because if you want to do a next generation sequencing, in some places, not everywhere, IHC is quite cheap. But if you're getting the MMR, I'm not talking of the routine IHC. Routine IHC is different if you're getting the MMR and this. So, and next generation sequencing would cost something, NGS, which would cost maybe, these days the labs, we have a lot of good genetic labs. So there's a lot of competition. So they are fighting. So maybe 20,000 is good enough. I have a tie-up with a lab which gives me at a cheaper rate because he gets samples, and that's a good lab, very good lab, MedGenome. So he gives me at a cheaper rate. So yeah, obesity, we know why obesity causes. So I'll not go into the details of that. Now, these are some of the trials we have, Janabi, Purolajal. This is in 2015 that had shown that a higher BMI is at an increased risk of endometrial cancer. So we can see the 3.3 is the relative risk is also increased. Now, coffee. This is something nice for coffee lovers. Anybody likes coffee in the house? Oh, I'm sure quite a lot of it. Yeah, coffee consumption and risk of endometrial cancer. There is a dose response. I have just put this meta-analysis of prospective cohort studies, which has shown that yes, there is a relative decrease. But having said that, I don't say in case you have migraine and all that, please don't go ahead. कि नहीं मुझे endometrial cancer कम करना है. But yeah, this is a study and this is a meta-analysis. So coffee has shown to reduce. Yeah. Again, right, you are very rightly said. It's a black coffee. And again, do not consume too much of sugar. That will increase the weight. And again, all the good effects would go haywire. Yeah, black coffee is quite good these days. Most of our movie stars, we keep hearing these days. It's how you develop a taste, I think. Eventually you develop. So, yeah, physical activity we know. Why I have covered, I know you all know this, but it is just that I was given preventive oncology, and in endometrium preventive is the high-risk patients we target, not the low-risk patients. What do we do with patients who are at average risk? Just you and me, what to do? We maintain a normal body mass index, we engage in regular physical activity, which most of the times I'm not able to. Breastfeeding rather than formula feeding, yes, which we have been since our, professors would be like, I still remember my professor would throw the bottle into the dustbin if she saw anybody, with that bottle feed. And using hormonal rather than non-hormonal, we are aware of this. And this is something newer screening methods. I'll just touch on this. We are not doing it. So I just don't want to give the wrong message, but I had to find out something new. So what happens is these days, what they're trying to do is, ladies who are, not very comfortable coming to the clinic, we give them vaginal tampons, which again, frankly speaking, I do not practice this and I don't know who practices this. It is just there. I'm sure the UK, United Kingdom and all practice. What they do, they give a vaginal tampon, and that vaginal tampon is taken and the DNA from there is studied to see. Now, when I was looking into the new era, I also found out, that the urine also of an endometrial cancer patient has these DNA methylation products which can also detect endometrium. But I think it is for the future now. This is way far beyond. We are yet to reach there. There are a few things called circulating tumor cells in the body. These days, a lot of these genetic labs will come and they'll be like, you diagnose the circulating tumor cells. And so, but these are not, as of now, we cannot apply it into the general population. We're not doing this. I think this is quite monotonous and I think they made it more complicated. 2023 earlier was quite simple. This is like really complicated, but yeah, when we are deciding treatment, we require so some things new. Now in this, basically what we have separated the non-aggressive from the aggressive histology. Non-aggressive is basically endometrioid, grade 1 and grade 2. Are the only non-aggressive. Other than that, everything is aggressive. You have a grade 3, it is aggressive. Clear cells, serous and CA endometrium behave very bad. Very serous because behaves like ovary. Serous CA endometrium behaves like an ovary. Clear cell is very bad because it does not respond very well to chemo. So I'll not go into the detail. What I want to classify, LVSI, I'm sure you all know, this is basically for the pathologist now. Basically, in this, what we have got is, because as I told you, in a C endometrium, I am sending for POL, I'm sending for MMR, I'm sending for the ER/PR. So if a patient is supposedly stage 2 and she is POL positive, then she automatically comes to stage 1. And if she is stage 1 and she is P53 mutant, she automatically goes to stage 2. Now again, I want to bring something in my clinical practice. We are not following this as of now. Yes, if I have a stage 1 who is P53 mutant, then definitely I might think chemotherapy for her. But other than that, if it is a stage 2 and she's POL positive, from maybe last few months, I will not change my treatment. Why? Again, I'll just let you know, this is a personal experience. We had this patient had undergone minimal access surgery, and she was stage 1. I precisely remember the stage 1, grade 2. And we got her MMR, we got her P53 and her POL. So her P53 was wild, which is fine, very good. Her MMR was proficient. Her POL was positive. And pole positivity is seen in only 6 to 7% of cases. I was out of my, I was so happy. Wow, I got a pole positive, because this is something, we require to publish. Oh, I got a pole positive. What is the incidence of my pole positivity and all that? Very happy. And this lady, she recurred in maybe 6 months' time or so. And where did she recur? Distant. She had her omental positive. Then I was like, how did she? The first thing I did was I called up the pathologist. I said, check her ovaries. Were her ovaries involved? Was she actually stage 1 or was she stage 3? How did it reach distant? Was it endometrioid or was it some other histology? Was it serous? Was it clear cell? But then, in serous clear cell, you'll get a P53 mutant. Unlikely that IHC would miss that. So the pathologist went back. She saw the ovary and she said, no, ma'am, there's nothing. This is just stage 1, ma'am. And stage 1A. This is stage 1A, not even 1B. She was grade 2. That was the only thing. So as usual, all our cancer cases, we have a tumor board discussion. And then we decide what to do, what not to do. So she was pole positive. Either ways, stage 1A, grade 2. She was 50 plus. So at the most, I would have given her IVRT, intravaginal radiotherapy, nothing more than that. No chemo, nothing like that. So this was discussed in the tumor board, and then we have a pole positive. So we all were like, why do we even give that? Pole positive is very good. But yeah, she recurred. And of course, then she got chemotherapy for her distant meds. So then again went back as usual. We would, rack our minds on what is wrong, what happened. I went back through the literature. There I found a study, a South Indian study. This was from South India, Dr. Koryakos. In fact, I was lucky to meet him in the Association of Gynae Oncologists of India. We had a conference December. He had taken out a paper where Indian patients with pole positive are not behaving well. The reports that we have are of Western reports. So he took out a paper, and I was, lucky enough, I met him, I talked to him. I said, sir, I have a patient pole positive who's recurred. He's like, publish it. He's like, take it out. Because he's like, people are not believing me. Once you take out, we have from different centers, then we'll realize that maybe Indian patients are actually not behaving. And actually, maybe there is more to that pole, that allele where they have these mutations and all, not necessarily what we are studying our pole mutation, and where actually this mutation is happening and how they're behaving. So since then, now I'm definitely irrespective of that, I'm still getting a MMR because I want to find out whether it's Lynch or not. I'm doing a poll because, yes, if we don't do studies, how will we know? So I'm getting a poll for everyone. I'm getting a MMR for everyone. But I'm not going to change my practice. I shall be waiting for POTEC 4. The results of POTEC 4 will be coming. So I shall wait for that POTEC 4. Only then I'll still decide. I'll still be, I think, skeptical about changing my practices till, this. So I'll not go into the detail. It's quite cumbersome and very lengthy. They've made it very difficult. I don't know how the students will now mug up so much. So, so this was the incorporation which we've already talked. Now surgery. We all know surgery. I'll just come to, this is basically sentinel lymph nodes. Why I bought this picture? Because it was sentinel lymph nodes. Now surgery, we all know, CA endometrium comes to us. We normally, what was the norm? CA endometrium coming to us, irrespective of what it is, where uterus confined. We used to hardly do MRI then. We used to do an ultrasound, biopsy. And then what was the treatment? Open, radical. मतलब रैडिकल इतना कि इतना मोटे मोटे लेग्स फिर लिम्फेडीमा के साथ आते थे वी गो अहेड विद हिस्टेरेक्टमी पेल्विक लिम्फ नोड्स पैराएक्टिव लिम्फ नोड्स ओमेंटेक्टमी एवरीथिंग मतलब निकाल दो सब कुछ then slowly it became minimum. It was like, are we actually doing the right thing? In fact, for that matter, I'm not going to touch into ovary, but just because I've talked about this radicality, even in ovary these days, we are, choosing our patients to whom to do pelvic, para-aortic lymph node dissection also. We don't haywire go and do everything because we are not gaining much out of it. And the morbidity is so much because as Dr. Kanika again had, I would again want to press on this quality of life. For a cancer patient, otherwise also, to come to know cancer, she becomes, she's mentally so disturbed that she's physically disturbed. Her family is disturbed, economically, her, time-wise, everything. So qualities of life is what we are saying. So surgery. Now, this is a very big question. Whether to do a lymphadenectomy or no. Actually, what should I tell you? It's still a controversy. We have, it's so controversial that you can debate on it for hours and hours altogether. But yeah, now we choose. So what we are doing is sentinel lymph node dissection. What is the sentinel lymph node dissection? We take a dye. This is basically ICG dye, this which you can see. This is done on a lap. I'll also show the robotic how it's seen. So lab, there are Striker company has this, where you can do an overlay. So what we do, this is a dye, ICG green dye. Comes in the name of Oro Green. We inject. We actually have to prepare it, dilute it. We don't give the full, the concentrated version. We dilute it. And in the cervix, we give it at the 3 o'clock and the 9 o'clock position. We go 1 millimeter, and then a 1 centimeter deep. So we do that. What is sentinel lymph nodes? It is the first lymph node which drains. So you can see this first lymph node. I'm here, the picture is not very clear because I think it's shining a lot. But there is a pathway which is going, and it is going into this. So this is the first. Now what happens is, like, sometimes, a lot of people, they'll be like, itna sara to green ho gaya, kaun sa first hai? Whichever is the first draining channel you see. Because uske baad to it will keep going. It will even go to the para-aortic. That doesn't mean all lymph nodes are sentinel lymph nodes. No. It is the first. You'll actually see a draining channel. It can be seen here. Draining channel which drains. So that's the first lymph node. Sentinel lymph nodes. So there are a lot of studies. Randomized trials have come which have shown that you can just do away with the sentinel lymph nodes. It has very good negative predictive value. So you have a sentinel lymph node, very rarely you will get a false, false positive or a false negative. So we are doing, but again, for a sentinel lymph node dissection, you have to validate in your own institute. This is what I am also practicing now, because there are randomized trials, but actually, are we doing the procedure correctly? Are we actually getting the sentinel lymph node? So what we are doing, what I have put into my practice also, I'm doing a sentinel lymph node as well as a full lymph node dissection. I'm trying to correlate that if my sentinel was negative, are my lymph nodes also negative? If my sentinel is positive, are the other lymph nodes positive? I will validate maybe around, a few numbers. And when I'm sure that, yes, we are getting good results, then we will change. Because a lot of, I think, cancer centers have now shifted to the sentinel lymph node dissection. Now, this is the para-aortic lymph node dissection. This is what we used to do. This, in fact, I did it recently. This was why? Because this lady was at slightly advanced stage, endometrium. She had reached the ovaries. So, bearing this, and this is done by us. We don't call surgeons. We don't call surgical oncologists. Done very much by us only. This is, you can see the IVC, the aorta. The picture, I think I put the wrong one. You can see the IMA going from here. This is the bifurcation of the aorta going into the common iliac. This is the external common iliac bifurcating into the external and the internal. This is the external iliac vein. This is the internal iliac. And then you can see the obturator. Up to there, we do a full dissection. So lymphadenectomy, whether to do, whether not to do, again, is we base on whether our MRI, we do a proper MRI. If it is showing 1B, then I go ahead with a full. If it is showing 1A and the grade is well differentiated, I do a sentinel, pelvic, and a generous omental biopsy in cases of serous and clear. Endometrial, they say you don't require, but I still go ahead with that. This is again laparoscopically done. You can see a full clear field where pelvic lymph node dissection up to the obturator nerve has been done. Now, yes, new era, I had to talk. So how could the new era come without the robotic surgery? And it is not a hype, actually. A lot of, maybe initially, because I just want to give this example. Initially, when open surgery was there and it converted to lap. People who are quite resistant. No. Lab will not clear as much as open surgery. Maybe there will be tissues. Even this is what the patients come and ask me. कि मैम अगर आप open करोगे और दूरबीन से करोगे, दूरबीन से सारा निकल जाएगा. I'm like, the surgery is the same. It is just that the mode is different. Likewise, hysterectomy. If you're doing an open hysterectomy and a lap hysterectomy, we don't leave anything behind. We do a full. It just depends how comfortable you are. So likewise, robotic surgery, it is not a hype, let me tell you, because I practice open, I practice lap, I practice robotic. So this is what I'm telling you. Because what happens is robotic lap, okay, definitely I have put some good points about lap. We have a haptic feedback, cost effectivity, avoidance of prolonged Trendelberg, flexibility in instrument configuration. That is because, we are standing near and we can change in whatever we can do. Robot assisted, we have a better 3D vision. And the robot is like it has a 7D. It's like a wrist movement. So unlike, and then what happens is, if ever I could actually, you're most welcome, whoever wants to come. If I ever have a robotic surgery, I'll actually show you all how comfortable it is for the patient, also not for the surgeon. बहुत सारे लोग बोलते हैं robotic surgery surgeon के लिए आराम हो गया कि वहाँ बैठे बैठे describe होने की ज़रूरत नहीं, जाके coffee पी के आ गए. No, yes, definitely for the surgeon it is important, because these surgeries tend to take slightly longer time than normal surgeries. It is comfortable for the patient. The trauma, I'll just tell you, when we go laparoscopic, I'm sure even my laparoscopics don't pain so much. I mean, people don't complain much pain. They don't have pain. But robotic, there is just minimal. Why? It's because that interface. Well, we are doing laparoscopic. It moves. There is a movement in the abdomen. I'm sure where everybody does, and you will realize there's a movement. In robotic, there is no movement. Why? Because there is a robotic port that goes. We have a remote center. The remote center will be in that subcutaneous tissue. And the robotic arms, surgery is obviously done by the surgeon only. The arms come and hold here. So that interface, there is not much movement, because you may move, but that interface doesn't move much. So I have personally seen from lab, definitely lab doesn't have pain. You discharge the patient very next day. Robotic, you can discharge even the very same day. It is that comfortable. So I'm talking of oncology, not just hysterectomy. When I do endometrial CA, the very same day I start them orally, and the next day I discharge. Take out the catheter and discharge. So, ma'am, again, extraordinary time, no, ma'am. Robotic, I think, it's faster than laparoscopic. Yes, why? You have a 3D. Ma'am, now again, it is not an individual work. When you have a robotic, you have to have a robotic team. You have to have robotic technicians. You have to have robotic staff who are so good at it. Because docking eventually with time should not take more than 5 minutes, ma'am. So what happens is definitely deep sternal work. Yes, I do not say no to it. But I'm sure even in laparoscopy, if you have a very fat patient, क्या आप ऐसे करते हैं? तब भी तो आप देते ही हैं ना sternal work. थोड़ा करके कि थोड़ा सा और कर दो, थोड़ा सा और कर दो, थोड़ा सा और कर दो. Anesthetist बोलेगा नहीं मैम, प्रेशर नहीं मेंटेन हो रहा है लंग्स का. नहीं थोड़ा सा और कर दो, इंटेस्टाइन्स आ रहे हैं. करते हैं ना मैम. So likewise, ma'am, robotic is also that much only. And robotic is for lab, you have a very long learning curve. I'm sure everybody of us will realize who we are all doing lab, and you have a very long lab. You suddenly can't say that, 10 surgeries or 10 surgeries are good enough to make me a very good laparoscopic surgeon. But for robotic, the learning curve is less. Maybe 20 surgeries, and yes, you're there. So it is that fast, ma'am. And whereas cost is concerned, ma'am, I don't know in how many days are you all, ma'am, discharging your lab patients? If anybody can just let me know, like in one day, ma'am. Second day. So, yeah, the only fact of robotic, the bad point I can send, eventually this is also going to go. Because I see a lot of, around Delhi NCR these days, I'm shocked to see, small hospital, they have a robot. I'm like, wow, that's great. So eventually, I think in the market, it is going to come up, cost is going to come up. The only drawback is the robotic instruments are very, very expensive. This is that is expensive. But again, as I said, people who've converted from open to lab will realize how comfortable lab is. So from lab robotic, how comfortable it is going to go. Yes. Come down. SSI Mantra is there. Hugo Ras is there. Da Vinci has X system, XI system. It is just in the market now. Eventually, it's going to be like lab. It's going to be just like lab. So, yeah. And what are the advantages? It is again the same, and this is, I'm talking oncology point of view. When I'm doing a hysterectomy with pelvic lymph node dissection with a lot of biopsies and all, there is hardly 5 ml blood loss, and hardly 5 ml. How do I say? Even one gauze doesn't get wet, so it is that comfortable. Robotic. These are some of the robotic. This is the sentinel lymph node, how it looks in a robotic. So basically, it's a firefly mode where you switch it on and you see a green, and then we take out. And this is a paper published. I'm also one of the authors there. That time I was working in Fortis Gurgaon. So we published this paper, Robotic Assisted Surgery, and these are 100 patients of endometrial cancer, which we published. Robotic Assisted Surgery for Endometrial Cancer, a comparison of surgical and oncological outcomes in patients with low and high BMI at an Indian tertiary care center. This was published in Robotic Journal, where oncological outcomes absolutely same as open, and we had better because these days all working women, or even if not working, what happens is, you know, the first thing the lady comes, मैं घर का काम कब से शुरू कर सकती हूँ, मतलब भले ही सर्जरी हो गई एंड ऑल, घर का काम तो करना है. सो दैट पॉइंट ऑफ व्यू शी दिस फास्टर रिकवरी. सो इसमें मैम, इसमें तो आई मीन द एज आई टोल्ड यू द वेरी नेक्स्ट डे, दैट सेम डे वी गिव देम टू ओरली, वी स्टार्ट नेक्स्ट डे टेस्ट. घर का काम मैम एक हफ्ते में तो आई थिंक करवा ही देते हैं पतिया, कौन सा वो ब्रेस्ट करने देंगे. प्रोफेशनल्स दे गो जॉइन वर्क विद इन 15 days मैम. एंड मैम घर का काम तो करवा ही देंगे ना, जिस पति ने करवाना है वो तो करवा ही देगा, और वो भी मोर की रोबोटिक पे खर्चा हुआ है, अब घर का काम करो. दैट वाज जस्ट अ जोक, बट या वेरी फास्ट रिकवरी मैम. एंड बिकॉज वी हैव कंपेयर्ड विद ओपन मैम, सो डेफिनेटली दैट वाज वेरी सिग्निफिकेंट मैम.